Catheter-associated urinary tract infections have become a prevalent problem in the everyday lives of patients, nurses, and other healthcare professionals.
In no way was she prepared for what happened next. Jerry's surgery was a success. She was recovering well when, on the third day after surgery, just as she was preparing to be transferred into the rehabilitation unit, she spiked a fever. Tests ruled out pneumonia and a blood infection, but she did have a urinary tract infection. Her surgeon told her it was from having the bladder catheter in. She had kept the catheter in an extra day because her son had requested it to spare her the extra pain of getting out of bed to go to the bathroom. A few days and a few antibiotic doses later, her infection had cleared up, or so everyone thought. As she was preparing to leave rehabilitation and return home, she began having more pain in her hip area. Her surgeon reassured her that it was most likely due to her increased activity as she progressed. Her incision looked good, and there was no drainage. 4 days after getting home, that all changed. The incision became very inflamed and started draining a reddish-yellow fluid. Her surgeon immediately readmitted her to the hospital and took her to the operating room to open the hip incision. Jerry was diagnosed with a deep surgical site infection. Cultures came back positive for the same organism she had in her urine. Her surgeon said she had probably seeded the hip infection from that urinary tract infection.
Catheter-associated urinary tract infection is the most common healthcare-associated infection. 560,000 nosocomial UTIs occur annually, accounting for 13,000 deaths. $500 million is spent nationally treating these UTIs every year. These alarming and unnecessary statistics all relate back to the fact that catheters are being left in longer than necessary. While healthcare provider education is often in place and very important, best evidence-based practice goes a step further. 3 strategies that prevent catheter-associated urinary tract infections include restrictions on catheter placement, reminders of in-place catheters, and stop orders. Indications for catheter placement restrictions are an important place to begin. By restricting the placement of catheters or identifying appropriate indications for catheters, CAUTIs can easily be avoided. Some indications include measuring urinary output in critically ill patients, improving comfort for end-of-life care, and bladder outlet obstruction. Inappropriate uses include catheterization of incontinent patients and catheterization as a means of diagnostic testing. In most hospitals, these following 4 steps are necessary for the removal of a catheter. First, a physician must recognize that a catheter is in place. Second, a physician must acknowledge that there is no longer a need for a catheter. Third, the physician must write an order to discontinue the catheter. And finally, the nurse then removes the catheter that is in place. The lengthy time this process may take often results in a catheter being in place hours to days longer than necessary. Thus, it is very important to have reminders of patients with indwelling catheters. These reminders in place are not only for nurses but physicians as well, and can include daily checklists, verbal and written reminders, stickers on a patient's chart and Foley bag, as well as electronic reminders. Unfortunately, reminder interventions can often be ignored, indicating a need for a stop order. Stop orders are when a nurse or physician is prompted to remove the catheter after a certain period of time or when a certain condition has occurred. Hospitals implementing such protocols have shown significant decrease in catheter-associated urinary tract infections, improvement of patient outcomes, and decrease unnecessary costs. Statistics show that there has been a 52% decrease in catheter-associated urinary tract infections. Statistics have also shown these protocols have decreased the duration that catheters remain in place by 37%. This translates to 2.6 fewer days of catheterization per patient. These measures have also saved $700 per 100 patients. Actions put in place by the healthcare team to achieve this goal could include 1. Put in charts similar to the ones seen here in locations such as workrooms and nurses' stations to serve as reminders to further assess patients with catheters. 2. Create motivational posters with the number of days that have passed without catheter-associated urinary tract infections in break rooms. And lastly, create a presentation to convince healthcare administration in implementing these protocols to improve the betterment of their institution. In conclusion, of the 560,000 patients diagnosed with catheter-associated urinary tract infections annually, our protocols have the potential to cut that number in half. Had Jerry's catheter been removed in a more timely manner, her hip infection could have been avoided, thus preventing undue pain, costs, and emotional distress.